Hello, guys, and welcome to Global Perfusion Community. So, we have Zahra with us today, and she's going to share her knowledge and experience. And today, we are going to have a wonderful topic. It's a very interesting session, and Zahra is going to share her knowledge on the topic that is Comprehensive Guide to Cardioplegia, Fundamentals of Cardioplegia. So, we welcome you, Zahra, on Global Perfusion Community.
Thank you so much. I started.
Yes.
Okay. Hello, everybody. Welcome to this webinar. I'm truly be happy to be here today and talk about this topic. And first, I think it's better to introduce myself. My name is Zahra Gambari. I'm originally from Iran. I have a bachelor degree in anesthesia, and I'm currently a master's student in cardiovascular perfusion. The topic that I want to talk about today is cardioplegia, and as you know, this topic is quite extensive. So I divided in 8 sessions, and now today this is the first session that we want to talk about the fundamentals of cardioplegia. Please jot down your question, and I kindly ask you that please keep your question to related to this session. And if you have some question about future section, please ask your question in respective section, because maybe we have some participant or audience who they are new to this topic, so we don't want to confuse them, and actually we want to interest them to this topic. So I start. Cardioplegia is a controlled and temporary arrest of the heart, and using a specialized solution stop the heart from moving, and this allowing surgeon to operate precisely and protect the myocardium, actually heart muscle, from ischemic injury. When blood flow is interrupted, cardiac cells are deprived of oxygen and nutrition and may die. In short, cardioplegia acts as a temporary shield that gives the heart time to safely withstand surgery without damage. So the question is, please go to the another slide. No. Okay, stop this slide. Uh, this is about our section that we will have them. Uh, so go to another next slide. Okay, here. Maybe the question is, why do we need cardioplegia? When an aortic cross clamp is applied, blood no longer flow into the coronary arteries, uh, and we know the main artery that's supplying the heart is coronary arteries during diastole, and it is actually it is normal when we clamp it. The heart deprived of oxygen and nutrition. I think it's better to talk about little about the anatomy of these arteries, actually coronary arteries. Coronary artery is divided into branch, right coronary artery and left coronary artery. Right coronary arteries supplies right atrium, right ventricle, inferior wall of the left ventricle, and part of the conduction system such as SA and AV node. Left coronary artery divided in two main branch. One of them is left anterior descending that supplies anterior wall of the left ventricle, anterior part of the intraventricular septum, and apex of the heart. And the another branch is left circumflex that supplies in lateral wall of the uh, actually lateral wall of the ventricle, part of the posterior wall of the left ventricle and left atrium. So we are going to be back. A beating heart have a high oxygen demand. Without stopping heart, irreversible damage can occur within minutes. By arresting the heart and lowering its temperature, the heart metabolism and oxygen consumption can be reduced approximately 90%. Go to next slide, please. Okay. In this slide, we want to talk about the key goals of cardioplegia. We have 4P. P number one is prompt. The heart must be stopped quickly. P number two is persistent. These areas must remain stable throughout the surgery. And P number three is protective. Actually, protective, yes. The myocardium must be protected from ischemic and reperfusion injury. And the last P is predictable. After removing the cross clamp, the heart should reliably return to a normal rhythm. Another slide, please. Okay. In this slide, we want to talk about the mechanism of cardioplegia. And first, we talk about the role of potassium. Classical cardioplegia solution contain high concentration of potassium. That when potassium level rise, cardiac cell depolarize and lead to sodium channel become inactive, and after that no action potential are generated, and the heart is arrested in diastole. Advantage of diastolic arrest is the heart remain relaxed and unstressed, minimizing injury. I think it's good to talk about a little about action potential. Please go to the next slide. um, Next slide, please. Okay. In normal cell, the inside of the cell is negatively charged compared to outside the cell, usually around minus 85 to minus 90 millivolt. This state is known as the resting membrane potential and is essential for the normal function of the heart. In this slide, I want to talk about the phases of cardiac action potential. In phase actually, phase 0, 0 to depolarization, rapid sodium, last, yes, here. Uh, in phase 0 to depolarization, rapid sodium influx and lead to cell become positive and trigger contraction. Phase 1 to initial repolarization, small potassium efflux and lead to sodium change close, sodium channels close. Phase 2 to palatal lead to balance between calcium influx and potassium influx, and it's lead to sustained contraction. Phase 3 to repolarization lead to strong potassium efflux and lead to membrane return to negative. And the last phase is 4 to resting state, that sodium channels remain closed and lead to cell ready for next cycle. I think it's better to talk about this more easily. The concentration of sodium inside the cell is less than outside the cell, so the leak sodium channels actually lead to influx of sodium into the cell, and conversely the concentration of potassium inside the cell is more than outside the cell, so the leak potassium channel lead to influx of potassium efflux of potassium outside the cell. And there is sodium potassium ATPase pump that lead to influx of potassium and efflux of sodium, and help to remain resting membrane potential around minus 90 millivolt. Some reference say minus 70 millivolt to minus 90 millivolt. All of them is true. And when the electrical signal travel to the cell, and actually when the action potential wanted to be a start, we need to actually the cell need to open the voltage gated sodium channels, and sodium rushes into the cell and started action potential. But when we use a high concentration of potassium as a cardioplegia solution, we increase the level of potassium outside the cell, and this lead to concentration difference across the membrane shift toward positive, and it's lead to this sodium channel. Actually, it means that voltage gated sodium channels become inactive and they can be open. So I think it's the main reason that why when we use some solution that they have a high concentration of potassium, uh, cause to or actually lead to stop heart during diastole. Okay, uh, I said when I repeat again actually, when extracellular potassium is increased significantly, usually 50 to 30 MEQ per liter or higher, I said the resting membrane potential become less negative, actually depolarized, and sodium channeled become inactive. No new action potential can be generated, I said, and the heart stop in diastole relaxed state. So energy consumption and oxygen demand dropped, and this protect myocardium during surgery. But it's important to use the normal range of potassium. The optimal range lead to ideal myocardial protection. But if you use a low dosage of potassium, lead to incomplete arrest, heart may keep beating. Actually, it means that hypokalemic. And if you use a high dose of potassium in your cardioplegia solution, it's lead to risk of delayed recovery or arrhythmias. So the normal range is very important. I talk about this solution in next session completely, but I think it's better to say a point here. For blood cardioplegia, the normal range of potassium around 20 to 30 MEQ per liter. And for crystalloid solution, the normal range of potassium is around 25 to 30 MEQ per liter. But there is a lot of factors that affected us to actually choose the range of potassium. For example, some patients that have um, um, uh, um, actually the potassium of their body is high, so we should to use less dosage of potassium. There is many factors that affecting of choosing the optimal range of that, so we talk about completely next session. Please go to the next slide, please. Thank you. Okay, now I want to talk about calcium overload. uh, During ischemia, ATP levels drop, and impairing ion pumps such as sodium, potassium, ATPase, and SER calcium. Sodium and hydrogen ion accumulate inside the cell, reversing the sodium calcium exchanger. As a result, calcium rushes into the cell, leading to intracellular calcium overload. Excessive calcium triggers hypercontracture, causing mechanical damage to the myofibrils, and it also activates destructive enzymes such as calpain and phospholipases, and high calcium rising apoptotic factor apoptotic factors. This combined effect lead to cell death. But I think it's better to say it more about this calcium overload. When electrical signal travel to the sarcolemma, the L type of calcium be open and lead to rushes calcium to the cell, and after that ryanodine receptor be active, and that affect on the sarcoplasma reticulum and release calcium from SR, or reticulum sarcoplasma actually, and it's lead to binding actin and mucin and start contraction. When the contraction want to be stopped, there are some pumps such as calcium that pumps calcium into the SR or sarcolemma, and there are some exchanger like sodium calcium exchanger that they influx three sodium uh, influx three sodium inside the cell and efflux one calcium outside the cell, and by this, they reduce the range of calcium into the cell, and this lead to stopping the contraction. But when patient face to calcium overload, this contraction actually cause tremor, and maybe the cell face to the death. So for prevent this injury, we added some drug in our cardioplegia solution. For example, magnesium. Magnesium is antidote of calcium, and by adding this, actually, we reduce the range of calcium into the cell, and we stop the tremor actually. I think enough about this issue. Please go to next slide. Yes, temperature. Role of temperature. I don't know. Dr. Peter Joseph Safar, he was an anesthesiologist that demonstrate when we reduce the temperature of the brain, the CMR2 of the brain actually become reduced. And by this, when we want to CPR the patient, we have more chance to alive brain. About heart, it is true, when we lower the temperature, by lowering temperature, we lead to a slowdown, a cellular metabolic reaction. We reduce the MvO2, and every 10 degrees centigrade decrease, about 50% reduction in energy and oxygen consumption. Therefore, cardioplegia solution is usually administered at 4 to 10 degrees centigrade. Please pay attention. I say usually. I say that the solution, talk about solution is about the next session, but when we use a cold cardioplegia solution, it is the temperature of that 4 to 10 degree centigrade. Sometimes we use warm cardioplegia solution, so this temperature is related to the cold, actually, cardioplegia solution. So go to the next slide, please. Yes, pH regulation. When blood flow is interrupted, lactic acid and metabolic products accumulate and lead to the environment become acidic. This acidosis can damage to the cell. To prevent this, we added some drug in our cardioplegia solution, or actually some buffer like bicarbonate, and maintain pH around 7.8 to 8. Our cells, all of the cells in our body, have two paths to respiration. One of them is aerobic respiration, and another one is anaerobic respiration. When there is adequate oxygen, the cell go to the aerobic respiration, and the Krebs cycle is active in this path, and produce a lot of ATP that is very important for cell and needed for this its metabolism. But when there is not adequate oxygen, the cell forced to uh, go to the anaerobic respiration, and in this path produce less ATP, and one of the product is lactate. Lactate is acid, so uh, it's lead to acidosis. But uh, I said we maintain pH around 7.8 to 8. uh, Pay attention, please. This range of pH is related to cardioplegia solution, not patient, because we know the normal pH in the patient is 7.35 to 7.45. Uh, I think it's good if I talk about the interpretation of ABG here. When you want to interpretation of ABG, ultraviolet gases, you have three steps. You have to do three steps. One step, please look at the pH. The normal range, I said, it's 7.35 to 7.45. More than this range, it means that the patient faced to the alkalosis, and less than, it means that the patient is faced to acidosis. And after that, look at the P carbon dioxide, or the pressure of carbon dioxide in the blood. The normal range is 35 to 45. More than, it means that the patient faced to respiratory acidosis, and less than, it means that the patient is faced to respiratory alkalosis. And in another step, let's look at the range of bicarbonate. The normal range is 22 to 28, but some reference say 22 to 26. More than, it means that the patient is faced to metabolic alkalosis, and less than, it means that the patient is faced to metabolic acidosis. And there is two strategy for ABG. One of them is uh, pH stat, and another one is alpha stat. We use pH stat in child, and we use alpha stat in adult. So maybe your question is why? Why alpha stat is better for adult and pH stat is better for child? Because when we use pH stat, we consider the temperature. Okay, we use cold cardioplegia, and it's reduced the temperature of the blood. And everybody know cold blood uh, lead to alkalosis. And maybe your question is why cold blood it may sell to alkalosis, because it's reduce the metabolism of the cell, and produce of carbon dioxide uh, reduce actually. And when the pressure of carbon dioxide in the blood become low or decrease actually, cause alkalosis. So in pH stat, we consider the temperature, and we injected the carbon dioxide to the blood. And all of us know that carbon dioxide is a powerful vasodilator, so it leads to the vasodilation in the brain. And for a child is very good, because they are so sensitive for hypoxia, and by this vasodilation we prevent them from injury, ischemic injury actually. But for adult is dangerous, because this vasodilation may be active Cushing reflux, and maybe lead to movement of emboli. And for some patients that have actually a high ICP, the pressure of their brain is high, it's very dangerous to use pH state because we vasodilated we vasodilated in the vessel of the brain, and by this the circulation of brain become increase, and we help to ICP become more than, and okay, it's so dangerous. So another point that I think good to say about pH, yes, the the dosage of potassium that we added in our cardioplegia. If you use blood cardioplegia, it's better to add around 10 to 30 MEQ per liter. If you use crystalloid, it's good to add 10 to 20 MEQ per liter. And if we use Delnido, it's better to add 5 to 10 MEQ per liter. I think it's enough for pH. Please go to the next slide. Yes, oxygen and nutrient. In blood cardioplegia, instead of a pure crystalloid solution, a mixture of blood and solution is used. Blood provides oxygen and glucose for longer surgeries, offers better myocardial protection. Uh, Go to next slide, please. Yes, type of myocardial injury we should to, or actually we must to prevent. One of them is ischemic injury. Ischemic injury because of lack of oxygen and nutrient during cross clamp. For prevent this injury, we use a high concentration of potassium in our solution. We reduce the temperature of heart to reduce the metabolism of the heart cell. And another injury is a reperfusion injury, damage from a sudden return of blood flow after cross clamp removal. For prevent this injury, we should to when we want actually to reperfusion, we do that slowly, so gradually, not rapidly, and we add some drugs in our cardioplegia to prevent some reperfusion injury. For example, like vasodilator, and other drugs. For example, lidocaine and many drugs that can add to our cardioplegia solution. So the another injury is calcium overload. Causes arrhythmias and cell death. I talk about this completely. Another injury is a free radical damage, actually reactive oxygen specific, or ROS. For preventing this, we should to do reperfusion gradually. We add, for example, procaine, lidocaine, antioxidant in our cardioplegia solution, and reduce the temperature of the heart, and many other things that we must do to prevent this injury. So go to the next slide, please. Yes, in this slide, we want to talk about the intracellular and extracellular cardioplegia. Cardioplegia is not just stopping the heart. It's about protecting the cell um at the metabolic cells, actually, it's metabolic level, actually. And when we use actually extracellular um, cardioplegia, like ST Thomas, like blood cardioplegia, works primarily outside of the cell. And if I want to say example of this, I say for you suppose, please, for example, you cutting off the electricity to the house. The light go off immediately, but the appliances inside are still cold. So versus of that is intracellular cardioplegia. penetrated the cell and modified metabolism actually, and metabolism directly, and preserving ATP, and controlling acidosis, or longer protection. So if I want to say example like this, for example, you cutting off the electricity of the house, and you turning on the cold system. And if I want to say example of uh, intracellular cardioplegia, I can say custodial means HDK. It's one of them. Intracellular, it's better, and give better protection. Go to next slide, please. Yes, phases of cardioplegia use. Number one is induction dose. Uh, it is rapidly stop the heart. A higher potassium concentration is used, and maintenance dose. It is repeated every 20 to 30 minutes, or given as um, continuous infusion. Potassium is lower than initial dose. Um, you know, the maintenance dose, the time of maintenance dose is related that which cardioplegia solution that you use. Okay, for example, for Delnido, we repeat the dose of that 2 to 3 hours later. But for the classical cardioplegia that contain a high potassium, actually, we should to repeat it 20 to 30 minutes. So it's related that which type of cardioplegia you use. And maybe the question is why we need maintenance dose. You know, potassium gradually decreased because of natural leakage, hemodilution, and excretion, metabolism. So we need to added maintenance dose. But maybe another question is why the dosage of maintenance dose is less than induction. Maintenance dosage is less than the induction dosage, because when we use maintenance dosage, there is still some potassium left from induction dosage, so we don't need to use a higher dosage of potassium. If we use a higher dose of potassium in maintenance dosage, it will be dangerous, lead to arrhythmias, and maybe we have some problem after reperfusion. So the dosage of that must be lower than the uh, induction dosage. And reperfusion, or hot shot, or final warm dose temperature is close to 37 degrees centigrade, used to wash out acidic metabolites, and prepare the heart to return to normal rhythm. But please be careful. Hot shot, always we don't use wash out. If we use cold cardioplegia solution or tepid cardioplegia solution, we must to use hot shot. But if our strategy is to use warm cardioplegia solution, usually don't need to hot shot. And I talked about this strategy in future section. So go to the another slide, please. Thanks. Factor affecting cardioplegia strategy. Um, these are important in selecting the type of solution and technique. Some factors is related to patients, such as age, EF, diabetes, severe coronary disease. For example, with the patient who have diabetes, we must to add insulin. Uh, okay, I think my connection is right or no? Oh, thank you. Okay. Um, I say that the patient who have diabetes, we must to add insulin in our cardioplegia solution. And the patient who have a low EF or a low ejection fraction, we must to use a less than of potassium in our cardioplegia solution. And some factors is related to the type of surgeries. For example, CABG, valve replacement, congenital surgery. Some factor related to the duration of cross clamp, line time require specific uh, solution, like custodial. And some factor is related to the quality of coronaries, severe obstruction, need for retrograde delivery. And I think it's enough for this slide. Please go to the next slide. Yes, sign of effective cardioplegia. Uh, our this sign is the heart stop quickly and completely. Actually, myocardial temperature below 50 degrees centigrade. EKG is flat with no electrical activity. After unclap, the heart return to sinus rhythm or meningeal ventricular fibrillation, VF. I means markers such as troponin and lactate are lower. Please go to the next slide. Yes. Uh, Common mistake and pitfalls actually. Inadequate distribution lead to some areas of the heart aren't protected, and this lead to post-operative dysfunction. Improper temperature control, too high or too cold, lead to cellular injury. And over dilution decrease hematocrit and insufficient oxygen delivery. Improper potassium concentration lead to post-operative arrhythmias. I think it's the last slide, but before I I think it's better to talk about a little about hemo dilution, and after that I finish my um, presentation. Hemodilution, by reducing blood viscosity, improves the uniform distribution of the cardioplegia. Uh, so, Cardioplegia solution, I means in the myocardium and is protected heart from ischemia. By a fewer red blood cell per milliliter, but the blood is thinner. More blood overall is circulating, so even if each unit carries less oxygen, the total oxygen delivered can stay sufficient. The body should to balances between concentration and volume, moderate dilution, keeps tissue oxygenated. Too much dilution lower oxygen delivery. So careful monitoring is very essential. And there is a formula, uh, Hagen-Poiseuille, I think the pronunciation is Hagen-Poiseuille, about flow rate. It's equal to pi pressure gradient and radius to force power per 8 viscosity length. By this formula, we understand that when we reduce the viscosity, okay, uh, the flow rate become increased. Why? Because uh, they have conversely related actually. But when we do it much, for example, when we do hemodilation too much, the delta P or the pressure gradient become reduced, and this lead to the actually reduce the flow rate. So this formula can to understand this issue. And maybe you ask me how can calculate the hemodilution. uh, one of the factors that we can use to calculate this is tissue oxygen delivery. Actually, DO2, amount of oxygen delivered to tissues per minute. Depend on pump flow. Actually, it means that cardio output multiplied by content, oxygen content, and oxygen content formula is 1.34 multiplied by hemoglobin multiplied by saturation of oxygen plus 0.003 multiplied by the pressure of the oxygen. And the goal is to maintain DO2 more than or equal 300 milliliters per minute per square meters. And another factor that we consider to hemodilation is hematocrit and hemoglobin. Such guidelines such as EACTS and STS say that the normal range of hematocrit for adult, if they are low risk, 22 to 25%, and about hemoglobin 7 to 8 gram per deciliter. And for the patient who have high risk hematocrit, we should to be around 25 to 28%, and hemoglobin, it should be around 8 to 9 gram per deciliter. And for child, they say hematocrit is be good to around 28 to 32%. And because it actually due to lower oxygen carrying capacity and brain uh, sensitivity, yes, sorry. And another factors that we consider them for hemodilation is SpO2 or mixed venous odo saturation. The goal is to maintain this around 65 to 75%. Odo level, it's actually SpO2 is odo level in blood returning to the oxygenator. And another factor is lactate level. Our goal is to maintain this less than 2 millimole per liter. And we, by interpretation of ABG, we can calculate hemodilution. There is some point. I think it's not bad to say them. Number one is hematocrit below 20% increases the risk of tissue hypoxia, cerebral ischemia, and myocardial infarction (MI). Hematocrit above 30% increases blood viscosity and pump resistance, risk of thrombosis, and impaired microcirculation. In patients with cerebrovascular, carotid, renal, or coronary disease, maintain hematocrit around 25 to 28% is good. And if hematocrit drops too low during bypass, packed red blood cell transfusion may be needed. Thank you for hearing me, and I think this presentation be useful for you. If you have question about this session, I'll be happy to answer your question. Many thanks.
Okay, thank you, Zahra. It was a wonderful presentation, and you have a wonderful knowledge, deep knowledge, and it's very inspiring for all the global perfusion community.
Thank you so
So
much.
now we are going to start the yeah. So now we are going to start the Q&A session. So before we move on to the Q&A session, I would like to tell everyone that today is Zahra's birthday. So we
Thank you
wish you
so
all
much.
a very happy birthday. You may have a wonderful year ahead, and God bless you.
Many thanks, Mr. Vivek. Thank you.
So it was really a wonderful presentation.
Thank you so much, and thank you, Aisha, for your positive message.
So guys, we are going to start our live Q&A session soon. So kindly comment your questions. We'll pick the question and Zahra will answer the questions. Okay, so guys, we are going to move on to the Q&A session now. So we have few questions over here. So I hope Zahra can see the question.
Say some use cabulate, some RL, and some NS, which is ideal. You know, I talk about solution next session, but I tell you a point. Cabulate is not protect the heart. Uh, so,
Okay.
you know,
So
but
according to you, which is best ideal for cardioplegia?
yes, uh, please repeat again. Okay,
According,
say
yeah,
which is better for cardioplegia protection? Yes.
yeah.
Okay, Kevlar, I think it's not protect cardioplegia protection, and the some new solution like as Delnido HTK is so useful, and I say that they are intracellular cardioplegia, and they are safe, but they are so expensive, um, and I think all of the hospital use such drug like Thomas because it's easy to use, and by arresting the heart actually protect the heart from ischemic injury. And in my idea, I think Thomas is better because classical um, cardioplegia I think is better, but maybe your idea is.
Okay, so we have one more question. So what is the strategy of lactate exertion
Lactate strategy, the question means that
to
why.
reduce the lactate? I think, yeah,
Okay, I say that cell has two paths to respiration. One of them is aerobic respiration, another one is anaerobic respiration. When
yeah.
not the cell goes to the anaerobic respiration, and I don't know now the biochemistry of this path, the glucose um, break down to some ingredient, and the last ingredient is lactate and it's acid. I don't know, the question is this or no, it's
I think, see, the question is what is the strategy of lactate exertion, right? So uh, on bypass, we usually observe that there is a increase in the lactate levels, and
yes.
after cardioplegia, definitely the lactates increase. So, what is the strategy to maintain the lactate levels?
Okay, I
How
said it.
can we? Yeah.
High carbonate, for example, to to reduce the acidosis by lactate. And maybe after we when we do reperfusion, the actually when the range of lactate become arise, um, we have two idea. In first, we think that this increase is about reperfusion ischemia injury, and another is sepsis. But if there is actually related to uh, ischemia, when added bicarbonate, the level of lactate in the blood rapidly decrease, And for example, there is some symptom of the patient's body. For example, the skin of the body is cold, but if the increase of the lactate is related to sepsis, uh, and has a fever, and when we add bicarbonate to the cardiopulmonary solution, uh, this not be modified, and actually the increase of the lactate in ischemic injury is rapidly, but sepsis is gradually. I don't know. Uh, the
Okay.
question is that or
Okay.
no?
We'll have a special session for this, for the management of lactate levels, because it is also a deep topic. We'll
Yes.
have one more session on this topic. So we'll go to the next question. So we have one more question. How do you give hot shot? Duration, dose, additives. Yeah.
It's good.
So how do you give hot shot?
The For calculate the range of hot shot is 5 to 10 milliliter per kilogram, and follow rate of that is, I think, 1 to 2 minutes. Sorry, uh, I'm sorry. We do hot shot in 1 to 2 minutes,
Okay.
and the pressure of that is 60 to 80 mmH actually. That you
So what do you add in the hot shot?
It's related to patient. We added some drugs, some mannitol, antioxidant, insulin. Actually, it's related to patient's condition.
Okay. So usually what you add in hot shot, and what is the temperature you maintain for hot shot? Is there
Uh,
any specific temperature?
37 degrees centigrade. I say it in my presentation
Okay.
because actually we want to wash out the acidic metabolite. So we uh, increase the temperature to we increase the metabolism of the cell.
Okay. So I would like to share my personal experience. So usually I add sodium bicarbonate, mannitol, and magnesium in the hot shot. So the sodium bicarbonate acts as a buffer, and the mannitol acts as a scavenger, which removes all uh, the
ROH.
residual potassium in
Yes.
the myocardium, all the toxins from the myocardium. And usually we give hot shot at a temperature of 34 to 37. That is enough. So it flushes out all the residual potassium, and if needed we can add lignocaine xylocard, and
Yeah.
sometimes we can add few drops of adri to that. So we'll go to the next question. Which cardioplegia is better, delnido or custodial?
Actually, mm, let me answer this question completely. About uh, do you interested to talk about uh, Del Nido and HDQuad completely here, or you want to talk about them in next session?
Do you have any experience with custodial?
I don't use custodial
Yeah,
HDQuad, but I think it's better for child. I think yes, or no, Del Nido is better for child. Yes.
I'm not able to hear you. Your voice is not clear.
Uh,
Can can you repeat again?
yes. Let me. My voice is good here now.
Yeah.
Okay. Uh, I say the advantage and the disadvantage of this in this solution. Delnido disadvantages of this Delnido is may need re-injection uh, in very long surgery, and The advantage of Delnido is longer duration, blood crystalloid mix protect, and protect myocardial, I mean, and reduce the mitochondrial injury. And about HDK or custodial, the advantage of HDK is very long protective without re-injection, sustainable for very long surgeries, such as transplant.
Yeah.
And the disadvantage of HDK is large volume may lower systemic pressure and a slower onset of cardioplegia arrest. It is enough, or I want to talk about this solution next session. If you want
Yeah.
to talk about them completely, I can say it more. Or
Yeah, we'll have one more session. We'll have a deep discussion on this topic. But I would like to tell you that, according to me, I think Del Nido is the best for all the cardiac procedures.
yes,
Custodial, yeah, custodial is mostly means custodial is used in long duration surgeries, and
yes,
it is used in heart transplants and organ preservation. But Del Nido is the best cardioplegia which we prefer, and it is good for myocardial protection. So according to me, I think Del Nido is the best cardioplegia comparatively to custodial. So do you have any idea about mini
mini.
cardioplegia,
What
or
means
microcardioplegia?
micro? Let me think. Uh, mini. Yeah, actually, my mind isn't now. Uh,
Okay, okay, it's okay. We'll go to the next question. Because as we don't have much time,
okay.
okay, we'll have a next question. So the question is, I want to know about facile cardioplegia and indications.
Uh,
Facile.
but means cardioplegia.
Even okay, even I don't understand this question. What is facile? There may be some spelling mistake, or maybe what is facile cardioplegia?
Uh, Let me think about facile cardioplegia. Uh, I'm sorry, that's a little tired. Let me a minute to think about facile. Uh,
Okay. I request Mr. Chinu, who has asked this question, to clarify this question. What is facile cardioplegia? Is it because I have not heard about it? Facile, FACILE. We'll go to the next question. So we have one more question.
HTK is
Yeah.
administered 30 to 50. What is your opinion about administering lower dose of cardioplegia regarding to the short time of cross-clamp surgery typically perform? Is that okay? Uh, can can you read it, please, for me?
Okay. So the question is, as I know that HTK is administered at 30 to 50 ml per kg,
Yeah,
what's your opinion about administering lower dose of cardioplegia regarding to the short time of cross clamp surgeon typically perform? Is that okay? What's your opinion about administering lower dose of cardioplegia?
but uh,
I think for a short cross clamp period,
yeah.
the Delnido is best, or we
Oh,
can use St. Thomas.
one solution is better. Yes.
Yeah,
Which type?
Delnido
Yes.
solution, Delnido
Yes.
cardioplegia and St. Thomas is best cardioplegia for short time,
Yes. It's
because
better for long.
yeah, HTK has a long effect.
Yes.
So better we can use. It's better to use Delnido or St. Thomas
For
for
example,
short
excuse me.
procedures.
For, for example, we use del needle in some surgeries such as longer cardiac surgeries, pediatric, and adult sometimes, and HTK for very long. We use HTK in very long, actually,
Yeah,
cardiac, such as heart transplant.
yeah, it is used in more complicated cases.
Yes,
So for short period, short procedures, it is best that we use Delnido cardioplegia or St. Thomas. There is no
yes.
need to use STK in short cross clamp procedures. So the next question we have is, what is the flow in hot shot and for how many minutes?
I said it in 1 to 2 minutes, and
Yeah,
the pressure is 60 to 80
yeah.
mmg. Mm,
Usually the hot shot we give is for uh, 3 to 5 minutes, and the flow is same as we give the normal cardioplegia, and we maintain the pressure around 80 to 100. It is just to flush out all the residual potassium or the toxins from the myocardium, and it helps the myocardium to uh, it, it helps the myocardium to start again. And we'll go to the next question. We have a same question about hot shot. What is the purpose of hot shot? Okay, so
we
we have discussed previously
we
the hot shot.
to wash out the acidic metabolites. And we, for example, we using the RO and injury.
Okay.
And
So
mini,
I think,
mm, I think the question was mini cardioplegia. Yes,
yeah, there is
but
a
my
there
answer
is a
is
cardioplegia called microplegia. So
mini or micro. Okay, I don't know my answer is true, but I said in involving injecting a small controlled
yeah,
amount of special solution, temporarily stop the heart. This allows the surgeon to operate on still and bloodless heart. The mini approach is used, I think, to reduce the volume of fluid given the patient, and which can be safer, especially in complex or lung surgeries. I don't know. I think this is mini cardioplegia, but I don't know. You, you mean the mean this or no?
okay. So I think we are at the end of our session, and we have
Uh,
one
uh,
more question.
sorry, about my answer was true about mini.
Pardon?
My answer was true about mini cardioplegia. To
No, mini cardioplegia is a different type of cardioplegia. It has a different delivery system.
yes,
Um, yeah. Uh, I think we have one more question over here. So I think it's about hot shot. Is it a warm cardioplegia?
it is one. What? Can you say it again?
Is it a warm cardioplegia? I think it is about hot shot, I guess.
The temperature of heart rate is
No, no, no.
37. Oh, so
The question is it a warm cardioplegia?
what means it
So
warm?
usually hot shot is not a warm cardioplegia. It is given before we release the cross clamp so
Yes.
that the myocardium gets oxygen, blood supply, and the heart's activity is generated, and the toxins and all the residual potassium and all the composition of components of cardioplegia which we had given earlier are flushed out, and it is maintained at the temperature of 34 to 37.
Another question is about potassium, yeah?
Yeah.
Okay, I said, when we use a high dose of potassium, we increase the level of potassium outside the cell, and the concentration difference across the membrane, I said, shift toward positive. So when we want to reperfusion, the heart can be beating. Uh, High dose of potassium cause arrhythmia and actually arrest heart, and it's very dangerous because maybe the patient face to death.
Okay. So I think we are at the end of our session. We have covered all the questions, and thank you once again for your
Yeah.
wonderful presentation.
Thank you,
And we
and
hope
thank
we see you soon again with another topic in another session. Till then, we wish you all the best. And once again, we wish you a wonderful and blessed birthday. May you have a wonderful year ahead, and God bless you. All the
thank you.
best.
And thank you for give us this opportunity to improve our knowledge. Many thanks for to GPC and for you, Mr. Vivek.
Yeah. So, guys, thank you for joining, and we hope you all join again with us live in the next session with a wonderful topic. So, if you have any suggestions, if you have any doubts, you can directly DM us or WhatsApp. And if you want a special topic to be discussed on the live stream, you can share your suggestions, your thoughts in the uh, comment section or on Instagram or on WhatsApp. So thank you guys for joining, and we'll see you in the next session. Thank you.
Thank you so much.